See, India is in the epicenter of diabetes quake. This is the current phase of diabetes. You go to any big hospital in not only in India but Southeast Asia, where maximum number of diabetic patients are there. You will see at least 30% of patients like this. So as of today, the recent ICMR guidelines for 100 million patients, so we have 200 million people to look after. There are annually in India, with whatever rudimentary statistics, we have 200,000 higher level amputation. Tragedy is that 85% of them are completely preventable. They are because of an infected neuropathic ulcer. So, it is felt that you remove the leg quickly, patient will walk with a prosthesis. That's not true. 5-year mortality after below-knee amputation is 85%. Why does that happen? See, the most sophisticated prosthesis of autobot which was 6 lakh rupees still weighs 2 kilo. So patient has to lift. Remaining part is a neuropathic. So it's like having a dumbbell of 2 kilo every step. So most of them die with a left ventricular failure. So this is the recent statistics from last week ADA, American Diabetic Association. And you can see this is the world statistics. And I think more diabetic patients die because of a food problem than cardiac issues. But that's not known because there is a glamour to cardiology, not to diabetic food. Again, it is a misnomer that infected neuropathic ulcer is innocuous. You can see in infected neuropathic ulcer has higher mortality than breast cancer, prostate cancer, and peripheral vascular disease with diabetes is only third after lung and pancreatic carcinoma. So beautiful feat like this, diabetes strikes, this is what happens. You need to understand why it happens so you can prevent it. So, see, remember first thing, foot ulcer is not a surgical disease. It's not like hernia, hydrocele, appendix. It is a complication of a background medical disease, which is going to continue throughout the life even after bariatric surgery. And prevention and treatment of diabetic foot is a road filled with roadblocks and potholes. Now, the changes because of in the foot because of a non-enzymatic glycation and neuropathy, completely change the characteristic of all tissues of diabetic foot. They are like the bones, muscle, ligaments, everything changes. But neuropathy you cannot prevent. Even with a good control, there will be some effect of neuropathy in the foot. So this is the algorithm. I don't know whether you have seen in or read in your medical school. So there are different type of neuropathy, vasculopathy. Every diabetic patient will go through this all in his diabetic life to lesser or more extent. And we have so many patients who are 30 years diabetic but they don't have ulcer. Why? Because in spite of this, if you keep the integrity of epidermal barrier, that is the skin intact, then patient can be walking. The moment the epidermal barrier breaks and forms the ulcer, the disease takes difficult to manage. So remember, maintaining the integrity of the epidermal barrier is the most important primary prevention strategy. And we'll talk about how to maintain that, but this is the only strategy. If you allow the skin to break, then the things will go ahead in a wrong way. So this is American statistics, where a diabetic patient goes to a podiatric nurse once a year. America saves $3.5 billion per year. This is Indian statistics, where a patient of an infected diabetic foot spends 50% of his annual income on treatment. These patients are vulnerable. The reason is, these are the first three reasons: neuropathy, immunopathy, altered biomechanics. So you have a very narrow window of opportunity. As of today, across Southeast Asia, it is not used for a simple reason, because this is a policy: no complaint, no examination. Because diabetic patient do not complain anything related to the foot. Nobody looks at their feet. So heart, kidney, eyes are established as a target organ. Foot is not still established as a target organ, even if it kills more patients than all three together. So this is one famous saying by one British author: the coming event always casts their shadows. Thomas Campbell was the author. You can see on the top with a small pustule which is treated on an outpatient basis, and see what is missed. This is what we call iceberg effect. and on that patient keep on walking and it will spread. So regular examination of the foot, annually, biannually, quarterly, depending upon the neuropathy, vasculopathy status, is the only way to risk stratify the patient and prevent the ulcers. So how do you do these all tests? So this is a big term. What you cannot measure, you cannot manage. So how many of us see the patient walking in our clinic? Hardly anybody. Everybody sees them sitting or lying down. So you have missed the diagnosis directly. So these are the things you need to see walking. Patient, if you comes walking, 10-15 seconds, you know what is happening. But our system is built like this, that we see patient only lying down or sitting. We never see him walking. So you miss a lot of the things. The last thing is the antalgic gait. If the patient is limping, it's not a diabetic neuropathy, it is a spinal stenosis. This is a normal velocity of a human walking, 1.4 meters per second. Okay. And these are the factors you need to check. I know nobody checks this. You know what is the fluidity of movement, velocity, cadence is the number of steps per minute. What is the step length? Do you know what is the step length when you walk normally? It is a 14 inches. The step length is measured from heel strike to heel strike. That is the 14 inches. Whether the patient has a balance, all this you can see when the patient is walking. So if you can diagnose his neuropathy just looking at him. And this is a test nobody knows in India, and not only in India, all over the world. Because this is only given in biomechanics book, not in diabetology. It is known as a timed up and go test. You ask the patient to sit in a chair like this, get up without taking support of the arms and walk 3 meters and come and sit. If he can do with it below 10 seconds, no neuropathy, 14 seconds, moderate neuropathy, about 20, bad neuropathy. And it has a specificity and sensitivity of 80%. Nobody does it, no? This is the vascular assessment. See, you must feel all the pulses. We tend to feel only foot pulses. You have to feel popliteal, femoral, all these pulses. So normally vascular assessment starts from proximal to distal, not from distal to. Then you must do the ankle brachial index. Ankle brachial index is you tie the sphygmomanometer between ankle and the knee joint and measure the systolic BP on the tibialis anterior tibial artery or posterior tibial artery. Then brachial pressure. So ankle pressure divided by brachial pressure is the index. That index normally is 0.9 to 1.2. Okay. So if you are regularly, as I mentioned, examining the patient once a year, and you do an index, if you start seeing that index is falling from 1.2 down slowly, that is the time to do a duplex Doppler, colored Doppler. Which, if it shows you the plaques are happening, then what you need to do?
So patient को shift है सर्वोजेनिक Yes, sir.
So if the index starts falling, that is the time to do a duplex Doppler. There are plaques, then you institute lipid management, antiplatelets, all this medical treatment. But unless you do ankle brachial index, you will not know. So again, that is something which is not done. Okay. Then you have the gold standard is a TCP, transcutaneous oxygen concentration. So that is of course technology which is not available everywhere. But just to tell you, suppose the index is normal, 1.2. Again, higher than 1.2 doesn't mean the good, better supply. It only means the arteries are calcified, you cannot compress them. And why should you check tibialis anterior and tibialis posterior artery? That is because if the wound is in the anterior area and the index is good, then you can still go ahead and do the surgery and you know that it will heal. So this is what is known as the angiozones. Angiozones are the areas where the wound is there and which artery supplies that you have to document. Now if the index is normal, this DCPO2 should be above 40. If it is between 0.9 to below 1.2, below 0.9 to 0.7, it will be 30. Below 0.7, it will be less. So below 0.7 up to it will be 20, but index of 0.5 is the impending gangrene. So that is how you can monitor this. These are the equipment. I don't know whether you have seen that. That's biostasiometer, tuning fork, filament, semi-spine strength filament, 5.07 gauge. This is a vibrometer. Do you know what is this? You've not seen a compass boxes in this? This is known as a goniometer. To measure the angle of the movement. But this is a very simple test, which is now there for, I would say, almost a decade. It was devised by British Ipswich Diabetes Center. So you keep the patient in a supine position, neutral foot, and with the index finger feel first, third and fifth toe. If you cannot feel out 2 out of 3, then it is equivalent to filament test. And a positive filament test is what is known as a foot at risk. It is a foot which is at risk of forming ulcer. The filament is tested on 5 points: first, third, fifth, metatarsal, midfoot and heel. Out of these 5, 3 patient cannot feel. It is the foot at risk. Okay, so that is how we have to do. Now, how do we normally walk? Have you thought about that? This is a normal walking cycle of every human being. So this is a heel stride, this is a mid stance, and this is a propulsion. And what happens in case of a diabetes? See, normally you put a foot down, it goes this, it touches the forefoot, and then shifts from first, second, third, fourth, fifth, and you take off. Now that doesn't happen. Many times foot takes off from the third MTP joint because there is a sensory motor loss. Foot normally falls in the center. In diabetic, it may fall in the pronation, it may fall in the supination. So supination. So foot is unstable, and if you see a patient of a diabetic neuropathy from behind, you will see he is wobbling. Do you know
we walk because the sensations are
sensation and motor.
Okay, that is why we walk like that. So if the neuropathy goes on, that is when we walk.
What I showed you is a normal walking.
Okay.
It's not for the diabetes. It's a normal walking, but that changes now.
Okay.
See, I'll come to that. But do you know how do you classify neuropathy clinically? Grade 0, where patient has no symptom and you cannot elicit any instrument finding. Grade 1, patient has no symptom but you can elicit the instrument finding. Grade 2, patients have complaints of symptom and instrument finding are strong. Grade 3 is a frank ulcer or a deformity. So grade 1 patient is also will be wobbling but not so much. But grade 2 patient, if you see, they walk like this. You see so many times in the OPD. And it is interesting, you must see patient of a diabetic neuropathy walking down the stairs. When normal person walks down the stair, what happens? Unless one foot is on the stair, other foot does not take off. Here patient has no sensation, so he wants to see whether the foot is on the step. If he doesn't see, he's going to topple forward. And that's why many patients lose the balance. So, I don't know also if every country building has a different height of the steps. There is a huge department, the best and largest department of biomechanics is in UK, in Staffordshire University. So they have done a study, the European staircase, American, South American, Asian, Indian, and they have shown that how the pressure changes in the foot. That's only for a biomechanic PhD. So this is what happens in diabetic patient. So I don't think this will run. But this is just to show you, see, every human foot has so many structures. But normal person never loses a balance. He never, even if he's walking, running. Why does that happen? Because of an anatomical structure called plantar fascia, which holds the foot rigidly together from the calcaneal tubercle to the metatarsal heads. And that integrity is lost. There is a rupture of a plantar fascia because of neuropathy. So foot becomes unstable completely. So this is a normal walking axis along the second metatarsal, second toe, which is absolutely stable in normal person. Okay, and in a diabetic neuropathy, see, normally tendoachilles is very strong. He controls the movement along with the plantar fascia. Now that this is lost, so the foot pronates like this. And first MTP remains on the ground. You just check yourself, stand like this with the first MTP pressure. Within 10 seconds, few seconds, you will get uncomfortable sensation. that sensation is lost. So the foot remains on the ground for a longer time. So normally there is a central heel strike like this in normal person, and then it is the pronation or a supination. So one foot will pronate, other will supinate. That's why patient is wobbling like this. So also this is very important. See, peak plantar pressure at this takeoff stage in every human being from young age to very elderly age is very high. It is 5 to 600 kilopascal. Kilopascal is the unit on which you measure the pressure. And just to give you an idea how much high pressure at a 15 kilopascals with a systolic BP of 120, all arterials are shut off. With a 6 kilopascal capillary circulation gets obliterated. That happens in each and every person, you, me, everybody. But the moment foot takes off the floor, there is an instant recovery. Okay. So every foot has a minimum anoxia ischemia, and you find there is an instant recovery, and that instant recovery is delayed because of non-diabetic glycation and hyperglycemia neuropathy. So delayed recovery and a persistent low-grade anoxia means what? It is a warmth erythema. Now this is the most cardinal sign. If you teach your patients at the end of the day to feel with the back of hand, 4-foot plantar skin, if it is warmer than the rest of the foot, he is heading for ulcer. Because the next stage in physiological cascade is exudate, which will form a blister and break down and form an ulcer. So, I tell all the physicians it is dangerous to tell the patient walk briskly to control blood sugar without checking neuropathy. And many patients tell us I walk 5 kilometers, 7 kilometers, and they don't check neuropathy. So this is a simple test. If you go abroad, you have now these thermometers. Abroad they have a variety of technology. They have a wireless sensor in the socks. So if you are walking beyond the capacity, it will send a message to your smartwatch or mobile that you have to stop. Similarly, there are bathroom mats at the end of the day. If you stand to wash or brush the teeth, it will send the message that you have walked too much. Now this is not something going to come. And also in America now there is a society against medijacking because all these data insurance companies are interested. So there is a society against medijacking. So also you will see I don't know whether you have seen nerve conduction study reports anytime. It shows sensory motor neuropathy. But these are two different components and affect the foot differently. So sensory neuropathy does this loss of sensation, inability to feel pressure, and then there is a hyperpronation in the foot, where motor neuropathy makes the foot stay on the first MTP longer time. Okay, and the biomechanical parameter which breaks the skin is known as a impulse loading. Impulse loading is pressure multiplied by the contact time. And you see classical example of this everywhere, sometimes our ICUs also, where patient is lying down in the bed, the heel is touching, so there is a low pressure for long contact time. So by 72 hours there is an erythema, then blister and gangrene. That's why we have started doing these pads. Because if this happens, there is no way you can, again patient suffers because he has to undergo many things. And in Amrita Institute, we have this sort of a pads tied to each and every diabetic patient, irrespective of department, if he is lying in the bed. So it offloads the heels. Okay. So this is a dictum. Longer the stride, higher the pressure, faster the gait, higher the pressure. So telling the patient to walk briskly for 45 minutes non-stop without checking his neuropathy is just taking him to disaster. You cannot prevent the ulcers. At least the ulcer never occurs immediately. First there will be callus. Callus is the precursor of the ulcer because pressure increases. But when the callus forms, you are one step towards the ulcer. So patient with these conditions should not do these exercises at all. You have to change their exercise schedule. And remember, teach the patient not to measure the distance in kilometers with minutes. There is no rule that they have to walk non-stop 45 minutes. Ideally, they should walk 15 minutes, wait for 5 minutes, walk 15 minutes, so the pressure reduces. And that is the way to do it, but unfortunately that is not done anytime. So remember, diabetic foot ulcer is a biomechanical problem. No amount of antibiotic dressing will heal unless you offload the ulcer bearing area of the foot. And repetitive moderate force of day-to-day walking breaks the skin. It's not something hurts the patient, it is a day-to-day walking, uncontrolled walking with hyperglycemia, incorrect footwear, all this contribute. So remember, foot is a very energy efficient machine. Normal person doesn't get corns, calluses, whatever may be the surface unless there is some specific cause. So if you take an X-ray like this once a year, can you tell me what is wrong in that? Again, all over India this is reported normal. But if you see clearly, there is a gap between first and second uniform. Anatomically there is no gap. So you draw the lines like this and allow them to transit cuboid navicular line. That angle is C, and known in podiatry as the angle of adductus primus. That angle you can measure with the goniometer. If it is 3, normally if it is increasing, that means patient is heading for a Charcot foot. Very simple test. This is a normal load triangle of a human foot, how the foot bears the weight. And normal weight bearing is along the second metatarsal, second toe. Now if it is a shifting, that is a very simple test. You keep the patient in supine position, foot in the neutral, and draw the line from tibial tubercle along the anterior border of tibia, which should go to second toe. If it is going laterally, that means again the foot is separating in the midfoot. So the foot weight bearing shifts to the midfoot. And then if you don't do it or patient doesn't listen and there is hyperglycemia, foot will break and form a Charcot foot. So the simple and Charcot foot, in the best of the European American Institute, there is a 30% failure. Okay, and that is why you should do this. If it is a Charcot foot gets triggered because of hyperglycemia, incorrect footwear, barefoot walking, you have to change the patient's footwear. See him walking and keep him in the regular follow-up. That's all that is required. Sometimes, very good forefoot amputation is done. All good surgery, and when patient starts walking, you can see at the tip there is a ulcer. The reason is again biomechanical. Normally, in the foot, the fulcrum is by the joint. 2/3 of the foot is in front of the fulcrum. Pulley is formed by gastrocnemius soleus. So when you reduce the length of the foot to half, the strength of the pulley is same. The moment patient starts walking, foot goes into plantar. So we have learned the equation in the school. Pressure is equivalent to force divided by area. Body weight is same, but the area is reduced. The skin will break. So you have to do is reduce the strength of the pulley by doing tendo-Achilles lemma. Again, this is a normal axis of metatarsal head. When the intrinsic muscle become weak because of motor neuropathy, there is a prominence of a metatarsal heads which are under pressure, and that can form ulcer. But how do you detect it before? You keep again the patient in a neutral position and drop the line from each metatarsal head. It should touch the heel skin. If it is falling in front of the heel skin, that means that metatarsal is malaligned. It needs a protection. And these angles need to be checked every year. So similarly, see the first, normally when we walk, all the 5 toes move together. So because of the non-enzymatic glycation, the capsule of the first MTP joint starts becoming fibrous, and the first toe undergoes what is known as the limited joint mobility. The normal extension of the first toe in standing position is 15, which you can measure with a goniometer. So every year if you are measuring the extent, and if you find it is from 15 becoming 13, that is the time you should change the footwear. See, normally all these footwear break at the MTP joint. So you have to have a rigid outsole, so it will not come under pressure. Okay? And then if you don't do that, then the ulcers occur like this. That is one reason why ulcers are more common in the first MTP joint. Many times you don't have to do that. When you wear shoes or like this, have you noticed within 2-3 weeks there are horizontal strips? That because MTP joint, one starts moving late, there is oblique strips like this. You just look at it and you know it is heading for ulcer. So how do you protect the skin? See, diabetic autonomic neuropathy causes a destruction of the sweat and sebum glands. Normally what prevents the skin from becoming dry even in a dry weather is that patient is sweating. Okay. Also, there is a sebum secretion which forms a layer. So if we wash the leg, water gets absorbed, there is a sebum secretion, so there is no evaporation. That process is lost because of a destruction due to autonomic neuropathy. So even if patient washes the feet, it will become dry within no time. So you have to teach him to wash the feet, make it dry, especially in the web space, because damp web spaces can cause fungal infection, and then apply moisturizer. Also, you must remember it is many times painful, painless sleep. Because of a neuropathy, there is a lot of pain. It is actually painless, but then it pains causing neuropraxia. So there is a burning pain. People apply ice pack, Ayurvedic ointment, variety of things that can cause damage. Also remember, moisturizer does not increase the moisture. It prevents the evaporation of the water. Okay. So these are variety of skin condition you see. Okay. So that is, last panel is not a dry skin, it is a fungal infection of the plantar surface. Similarly, this second is what we call the diabetes bullae. You see this third panel, if you see something like this, you don't have to ask the patient whether he is on dialysis. This is a typical end-stage renal disease, skin changes. You can look at it and you can see. Then this is because of acupressure slippers. Okay, and everything which happens in the foot is not because of a diabetes, it can be vasculitis also. So nails, there is a very old study done by one Dr. Bose in 1981 or something. He had shown in 150 cases that wrong cutting of a nail causes damage to the toe and toe amputation. So trimming the nails, the correct fashionable nail trimming is slanting like this. That's highly dangerous in diabetic neuropathic patients because the toe undergo crowding because of intrinsic muscle weakness. So the nails turn inside. So you have to cut them sharp, straight and file the edges. The best time to cut is after bath. And if the patient has, because of this neuropathy, joint stiffness, somebody else has to trim the nails regularly. Otherwise you see the nails of this type always. They are difficult to treat. Now this something like this only first toe on both the side becoming little discolored is because of a tight shoes, which causes subungual hematoma. So how do you do biomechanical examination of the foot? See, any patient who comes with a neuropathy, you must measure the calf circumference. If one calf circumference is less, it's not a neuropathy, it is a spinal stenosis. Then these are a variety of neuropathic feet you see. Now, we have seen so many equipment and technology for sensory neuropathy, but there is no really easily available technology for motor neuropathy. So this is a simple method. You keep the patient in supine position, foot neutral, ask him to hold your index finger and pull. If he keeps the toe straight, it's a good power. If he does this, it's a moderate, allows him to feel poor power. Then many times you have a diabetic patients with a edema. It can be nephrological, cardiac, so many things, lymphatic, or it is the infection. Now one thing, this is known as the Stammer's test, which is to rule out lymphatic edema. So on the second metatarsal head joint, on the dorsum, if you cannot lift the skin, it is 100% lymphatic edema. It's not any other edema. Similarly, these are the tests to decide which tendon is not working. Similarly, this is known as the too many toe signs. When normally you stand behind any person, you don't see lateral toes. But in a diabetic patient, if you see fourth and fifth toe, that means midfoot is collapsing. So these are the tests which needs to be done by paramedics. So remember, offloading is a gold standard and cornerstone, and footwear is a cornerstone of offloading. So this is a simple prescription of the footwear. Footwear should do what foot cannot do. Foot doesn't fall in the center, pronates. All this can be corrected. And this is a prescription triangle of a footwear. Those sports shoes are written specifically for one reason, because sports shoes have a built medial arch. But you can have any footwear. Also another thing, see, in Indian culture we have a culture that we purchase a footwear, it should last for 3 years. It doesn't happen in diabetes. Like, depending upon the blood sugar, you keep on changing medicine, insulin. The footwear may require repeated change as the neuropathy progresses. Sorry, it's going behind. So, how do you reduce the pressure on the foot in case there is a callus? See, if there is a callus, you trim it, have these 2 insoles, each of 7 millimeter of microcellular rubber of microcellular plus MCP, and ask him to stand on one and make a cutout and offload, put it in patient's footwear, you offload it. You have this adhesive pad available even in our hospital. They cost only 120 or 30 rupees. You can cut out and put on patient's foot or in the footwear, and the ulcer is offloaded. See, what keeps the toes anatomically together is the adjoining toe and the small muscle. Both are gone in this patient. So unless you support the second toe will dislocate. So you have to have fillers in the insole, or you have artificial toes like this, which are available in Bombay and other places. If the metatarsal head is prominent, you can have a pads like this which you can hook and protect the metatarsal heads. So this is for the forefoot ulcers offloading. Foot like this does not require amputation. You can have what is known as a foot bed or molded insole with ankle foot orthosis, and patient can be still walking. So what are the causes of ulcer not healing? 95 out of 100 is patient is walking on that. And out of this remaining, the most important is the incorrect method of dressing. And these are the agents. They are not used anywhere in the world except Southeast Asia. So we should stop using them. They are most dangerous for the foot moves. This is the ideal method of doing a simple dressing. You don't need any technology, just saline and whatever can keep wound moist. Remember, there is a saying, dry wound is a dead wound. So don't allow the wounds to become dry. So remember, callus is like a benign breast lump. You cannot leave it because callus is either hiding the ulcer or it's a precursor of the ulcer. So also, as I told you earlier, the disease is going to remain. So the moment you tell patient you are cured of ulcer, he will not bother. You have seen how oncology patients come regularly for follow-up because they have fear. So you have to bring in this concept of cure is equal to remission, and you have to have a 5-year ulcer-free survival concept. Okay. Also, you have acute coronary units, stroke units. You need a very aggressive acute diabetic foot unit in every hospital because time is a tissue. More time you lose, more tissue is going to lose. But even for a simple wound, you need to check the circulation. And remember, you need to heal the wound rapidly because activity and mobility is longevity. If you keep the patient offloaded, it is a high cardiovascular risk. And you need to have a team. The minimum team can be diabetologist, paramedic, if required a surgeon. And these are so many studies which have shown a team can have a better wound healing and salvage of a foot. Remember, but the most important member of the team is patient and his family. If they are not interested, no food can be saved. Minimum you should do is don't allow the patient to walk, otherwise they literally walk to death. They go into sepsis, nephropathy, and they die. And what you need is just adequate knowledge of a peripheral neuropathy and biomechanics to prevent the ulcer. And you have just regular examination, clinical examination of the foot, and find out high pressure area and protect them with a proper footwear or orthotics. That's the only solution when you have 100 million patients. This is a 3-minute examination advice of a foot. You have to do simple things. You just feel the dorsal is posterior tibia, see whether dorsum of the foot has hairs and not, see the skin, and ask the patient to separate toe to find out intrinsic muscles are working, and see what footwear is he wearing. So it tells you about neuropathy, it tells you about vasculopathy, it tells you about patient's knowledge about self-care and about the footwear. Okay. So, but this is not successful treatment of diabetic foot. What you need to is teach the patient to do a self-care every day night, wash the feet, see. So we, Diabetic Foot Society, has these 10 commandments of food care, which are, there on the website. They are widely circulated. So feet are trying to be saved. Okay, and at the end, this is a very famous Sanskrit saying, which means one who walks his fortune marches ahead. I think you want all those millions of patients' fortunes to march ahead, so you have to save their feet. Okay.
Thank you very much. Thank you very much. So, you can proceed. Any questions? Any question? So, how do you, sir, now we understand that I think walking seems to be the biggest problem in a diabetic too. That's how it looks like. So, on the perspective of exercise, then what exercise would actually they do need to do?
You can have a stationary cycle, but you can walk. But you need to monitor the walking. See, you tell me which diabetologist tells that you walk this way. They say walk briskly. Brisk walk means long step length. So that puts the pressure. So you have to teach them to walk 15 minutes, wait, sit for 5 minutes, walk 15 minutes. Do stationary cycle. There are in abroad there are hand bicycles, which you can do. These are not available here. So there are a variety of things.
Any other exercise rather than putting pressure on the leg, isn't it?
Yeah, so you can do upper body exercise. That will also be reduced.
Right. And is there a specific footwear apart from the footwear that we sell over here or the footwear that we customize?
See, there are 4 points in the footwear. It should have a rigid outsole. It should not have any buckles on the strap, overlapping strap, because there is a edema at the end of the day. Because the autonomic neuropathy opens the shunts, and shunts are widely dilated. So you exude the fluid out, and after midday patients' foot starts swelling up leg. So you have to have straps like that. You should always wear proper socks, and it should have a good insole. See, all these footwear what we are using in India, I call them unphysiological, because they have only 3 millimeter insole. Now anybody can see after few weeks there is a depression at the first MTP joint. That is known as a bottoming out of the insole. So insole has to be 7 millimeter. And it should have a shore hardness of 25 to 35. Shore hardness is the property of a material to distribute pressure. There are shore hardness meters available, but the simple thing you can do if the patient is, most of the patient come to us saying that we have spent 5,000, 6,000 rupees, and I know it is wrong. So if I take out an insole and take a 1 rupee coin and press on that for 10 seconds, and if I remove it and if the mark remains, that means it is not distributed pressure.
The mark remains. In fact, if I remove my shoe and I find it not to be plain and it to be having different parts, means the pressures are not okay.
Pressures are not. So ideally, how do you measure for a footwear? That of course I did not cover. The length is from tibial tubercle to the tip of the second toe, which is the longest toe in human beings. Okay, and from first MTP to fifth MTP width, all over you keep 2 to 3 millimeters extra for swelling. And it's ideally required to tell the patients to select the shoes in the evening, because the foot is swollen, and the size will increase by 1. And also see, most of the patients with established neuropathy go to the footwear shop to select the closed shoes. Normal size, they won't feel the shoe is in the foot, so they tend to select lesser size. So by evening it is 2 size less, and that causes problem there.
Sir, have you any time seen isolated diabetic foot without problems in the problems with the heart or kidney?
So many.
Isolated, only isolated. So you need not have diabetes, basically, you need to say. You can still have.
You can have non-diabetic also can get this. Basically because of a improper footwear. See, you will see most of the ladies wearing these high heels. So the forefoot comes under pressure. So if you wear them for 10 hours like this and walk, the pressure comes. The skin always reacts to pressure. So pressure will cause cons in a non-diabetic. And how do you differentiate between callus and con? See, callus is in the epidermis, and con goes is a conical, it is in the dermis, up to dermis. So even in a diabetic patient, when you vertically press on the corn, it is extremely painful because it is touching the nose. While in a callus, it will not be painful.
So classically, many of our patients have these arterial insufficiencies, isn't it? How safe is it to put these arterial lines? How safe is it?
That's a debatable question.
Uh,
But then it is ideally, scientifically, you must do a duplex and see if there are plaques.
There are plaques, isn't it? Because at the end of the day, the supply will go down the moment
If
after
the
the
plaques get destroyed, it will go distally.
It will go distally. So, matlab, we in arterial line will be very careful basically to take it, isn't it? Huh?
But then at least, if not duplex, you see the handle of the flow.
What is the flow down there?
And if the triphasic flow, that is there is no flux.
There are no plaques, yeah.
There are now, these machines, VAS lab machine, which measures the index at every level, femoral, popliteal, like this automatically. The hospital should purchase it. It costs, I think, cheapest is some 5.5, 6 lakhs.
So we normally give our patients of oncology, these patients, we give them floatrons and we give them thromboembolism deterrent stockings.
That is okay.
That is not a problem. No?
See, also when the diabetic patients travel, if they are sitting in the plane and all like this, the seat presses on the popliteal vein, and many of them get a thrombosis. That's why they must wear stockings while traveling always. Similarly, many patients in outside Bombay district places travel with the ST buses and remove the footwear and keep the feet on the floor. But underneath that is a machine. So this is the metal plate is very hot, and we have seen so many patients
After
getting
that,
burns.
yeah. So we do have a lot of patients with arterial, with peripheral vascular disease, for that matter, arterial insufficiency. Now, what we have a dictum in antibiotic use is the fact that we need to get the antibiotic at the right dose, at the right time, at the right place. This is the dictum. It has to be the right antibiotic at the right dose. Now, when we actually have peripheral arterial disease, there is absolutely reduced blood supply down there. It is a big mystery as to how we should dose, because you dose higher. Take the example of vancomycin, one of the highest studied drugs. So we are now going towards an extent that in order to get vancomycin in the right place, at the right dose, we have to give close to 2.5 grams, which is a very high dose. Now this is for normal people. Now, when you give it for diabetic foot, say for example, if you give vancomycin, the penetration into that area would be even more lesser, isn't it?
So what we do instead of that, we use the stimulant beads, which are beads where there is a special powder which you mix with the vancomycin, other drugs, and create a bead and pack them. So the concentration at the wound level is 1,000 times more than IV.
Yeah.
And it is cheaper. It will cost only
So, but sir, so for example, the average diabetic foot patient that comes in, okay, the average diabetic foot patient, we would probably not be using those beads.
No, if there is an infected wound, we will use it. So many times.
We've used it many times. But sir, for example, you have a patient of foot and you put Magnex foot, for example, okay. Do we need I always had this doubt whether we should increase the dose, because there are many studies that have actually looked at thigh muscle to understand how much.
That's true, but then if there is a wound there, the beads can be put.
There we can put it, but what about those in which we are not putting the beads?
No, then you have to judge how much is.
Just judge it, no? Because very often, it happens we have antibiotic failure, though it is sensitive. And
I know that that's a dilemma, but as far as wounds are considered, there is a 3-nation study from I think Europe, USA and Africa, which has been published by Dr. Lipsky, who is supposed to be the
yeah.
So he has shown that IV antibiotic and oral antibiotic have same effect.
Same effect, yeah.
You don't have to give IV.
Hey, right. That is, we know now that because the bioavailability of many of the drugs are almost the same, so there is something. There was one more doubt I had.
These all things, Sanjith, will happen only if you don't prevent the ulcer.
The answer I feel is prevention. So how frequently a diabetic patient should visit and whom they should visit?
Ideally, anywhere in the world, all this what I showed, even in Amruta Institute, it's not done by doctors, it is a paramedic.
Paramedic.
In Amruta Institute, paramedic do computerized scan, give contact cards, do everything. And they have a format, it is automatically filled on the computer.
So we can't do it here?
Here means they should assign a space and paramedic who can do that. So that is going on for the last 20 years, 22 years. And those paramedics are trained there. There is a paramedic course of 1.5 years. where they are trained, they assist even in surgeries also. They do routine dressings. Nobody, doctors or RMOs are also not involved in callus difference.
Just them, they are doing it. So, in this entire presentation, I didn't see about therapy with respect to hyperbaric oxygen.
No, that I have not. It is
But
only
they are
biomechanics.
so, hyperbaric oxygen is all useful in this.
Now there is a new study which have come from, I think, Andrew Bolton, he has done a study in UK. They have shown that topical oxygen is as good as a hyperbaric.
You don't need to increase the pressure.
No, you can
Just give oxygen.
Oxygen to the local. There is a
Machine that comes with giving
which is
oxygen.
attached to the concentrator.
Yeah.
Because many patients cannot be given hyperbaric. There is also transport problem, logistics. The cost drastically reduces because topical oxygen costs 3,500 for 2 days. Here, if the patient has to come from far out by ambulance and all, just for hyperbaric, it costs. And many patients with a lung disease, cardiac, then you need a multi-patient chamber where a paramedic can sit there. That's the cost.
Any questions? So,
So non-healing ulcers, other than in lower limbs, how common it is? Like
No, there are
In
venous
diabetes.
ulcers. There are vasculitis ulcers. Say Suresh, who is one of our fellows, he has written a thesis where we have done 350 biopsies and showed these ulcers are there, either vasculitis, liver vasculopathy, pyoderma, gangrenosum. So they need to be treated properly. Many patients require endoxan, some patients require microphenolate, some patients require increasing doses of bisalon. So then only they will heal. Venous ulcers are there, you need to do a EVLD, that is laser treatment, and then give a 4-layer bandage which heals the ulcer. So they are common in many diabetic patients because of neuropathy, they have no sensation. And though arteries are mainly affected, even veins are affected.
sir, at what level should the person come to the hospital for this evaluation? Diabetes, you are diabetic foot
So
patient.
if you have a diabetes, you must undergo this evaluation once a year.
Once a year.
If you find anything positive, then you reduce the duration of follow-up
So
examination.
in Mumbai, where do you do this entire thing?
I don't know anybody who is doing this.
Oh, there is no one doing it in Mumbai.
Some patients, see, some diabetologists have all these machines, they have scans, but I don't know whether they don't know how to read them.
So that is an area of need, isn't it?
Yeah, we can set up, I have told Kunal many times that you
Ah.
should set up.
Because if that is the case, then I mean we will prevent. As you rightly said, prevention is the biggest thing.
Once the ulcer occurs, no, my belief is it's the beginning of the end.
When the ulcer occurs. So even a small tiny epidermal, this maybe it's
See, if the patient is examining the foot every day night or somebody else in his house, you have to see 5 things. Whether in between the toes there is a fungal infection, whether there is any swelling of the leg, whether the skin is broken somewhere, how are the nails, and whether there is a localized swelling of anywhere. Just 5 things. And patient has to wash his feet, make it dry, apply moisturizer, not between the wet space, because see, fungal infection is very common. And fungal infection has 3 components: fungus, the host, and the environment. The host is immunocompromised, fungus you have no control, but environment you can control by keeping it dry. So even wiping many times remains damp. So you need to wipe with sanitizer, so it will, or spirit.
Sir, so many of the people around go to this pedicure people,
Because they don't know about neuropathy.
They don't know only. So pedicure buses can be dangerous. It's where we have seen so many patients come in over here.
See, as I told you, beauty parlor, it's a slanting nail has to be cut. That in a diabetic patient will turn inside.
Will turn inside. Once it becomes slanting, it turns inside.
It will slowly turn.
It will slowly turn
Yeah.
only.
And then it starts ingrowing. Then you have to do the surgery, okay, to remove that inflamed part.
So you mean to say we should never go to the pedicure?
Not a diabetic patient.
Not a diabetic
You can
patient.
go to a diabetic foot clinic where the paramedics can cut it properly.
Oh.
But we don't have in Mumbai,
So you can cut. See, cutting is not a high-tech job. You just take a simple nail cutter and cut it straight. You have to keep it, at least there is a distance between the cut nail and the skin has to be more than 1.5 millimeter. Otherwise it will get stuck there. And then file the sharp edges with a nail cutter file.
Oh, it should be ahead. The nail should be
It
1.5.
should not be cut flush with the
Not flush
skin.
with the skin.
Otherwise it will get
Yeah,
stuck.
yeah.
That's a simple, because if you cut it flush, then the callus grows underneath. Because of the skin changes rapidly in neuropathy. So this is not a high-tech job. And in Amrita Institute, we have been training for 20 years. Girls who are not even SSC pass, they are say 7th, 8th standard pass. We train them for 18 months and they are doing everything. Many of them have gone abroad in Gulf and all. So it's not a something, but it's a patient cannot bend and cut it. Many patients have neuropathy, they don't see, so they are likely to cut the skin.
So that means when you go to the salon, you should tell them don't cut it. It's curves. Cut it straight.
That they won't understand.
Huh?
Diabetic patient.
Diabetic patients should not go only, no?
For you to open diabetes beauty parlor.
That's a good idea.
That was weird for me.
It's a big scope.
No, it's a huge scope, right? It's
It's a good start.
Huh?
Startup,
It's a
good
big
startup.
Good startup, really. Diabetes beauty parlor. That's actually very good because it's not
Diabetic
only
food
that,
beauty
so many other
parlor.
diabetic food beauty parlor. Yeah. You sir, actually that's an area of need actually if you ask me because that is one of the prime. We have seen so many patients come like this.
So you start. There is a lot of scope. You can get funds from all these agencies.
You recorded the whole lecture? ठीक है. So are there any questions? Any further questions on diabetic foot? Anyone? Any? Of course.
I'll send you some e-books.
हाँ.
We'll circulate.
हाँ,
They
I
can
will.